I haven't seen you since your running injury, so you're better.
Yeah, getting there.
So.
I learned this week that I actually have 3 fractured ribs and 2 bruised ribs, so explains the pain, but
Still uncomfortable.
still uncomfortable, yes.
Okay, we have some referrals for you to look.
I have a cheat sheet I can pass out, I think that would be helpful for several items today. So the first referral is actually captured at the bottom of that sheet I just handed out. These are dollars that Senator Akshar made available.
Yes, I do, I'm sorry.
To us. They're Oasis dollars. And it's a one-time only, so it wasn't something I could add to our existing school-based substance abuse prevention program. So I submitted the plan and it was approved, and I'm now asking to be able to bring in those state aid dollars and also enter into in essence, a contract with Lore's prevention, substance abuse prevention services.
We've done this right along.
No.
I don't think that we've ever contracted with Lore's, but
That name rings a bell for some reason. Okay.
How many schools are they gonna go? To all of them?
they're going to go into the schools where we're currently not able to provide school-based prevention. So that would be Greene, Oxford, Acton, and Bainbridge, I believe, those 4 school districts. It's an 8-week, I believe it's 8-week curriculum, evidence-based. So we tried to set it up where we get the biggest bang for our buck.
Questions? Mr. Roger Moser.
I'll second.
Mr. Mastro seconds. Further discussion? If not, all in favor?
Aye.
Opposed? It's carried. Capital Charities.
By the way, Krista wasn't able to be here today. Her father's quite ill. But the referral for Catholic Charities was to actually reduce the contract. That's A4320.51. It's a result of some changes in state aid. But we're requesting that that budget line be reduced by $13,350.
This is for the 311.48 half year.
It's for what? I'm sorry, Dennis. What?
This is you got here the Catholic Charities budget at 311.48, and you want to reduce it by the 13.
Yes.
This amount.
Yes. So if my math is right, it would then be $311,048.
Okay, so this number does reflect that then, what we have on our paper.
Yes.
Okay.
Questions?
How when you add all these contracts up, what do they come to?
That would take me a little time and a calculator.
And how does that compare to last year?
Some went up, some went down. It really depends on the state aid. These contracts are entirely supported by state aid, so any changes in state aid changes the contract.
Mastro moves. Mr. Corey seconds. Discussion? All in favor?
Aye.
Opposed? Carried. Okay.
It's the next RSS, is that right?
No, that was all.
Oh, that was all of them. Okay, and do we also need to increase the revenue? A 3490, state aid,
It was part of
that's
it.
part of it?
It was
Okay,
part of it.
all right.
Yeah.
I promised Christie I wouldn't blow it.
Okay. Looks like we're down to department credit card.
For a few years now, I've come to my standing committee and this committee requesting a departmental credit card. And most recently, there was another purchase that we needed to make in a rather timely manner, and it was difficult for me to go back and forth with Betty to try to figure out how and when to borrow her card in order to make the purchase. At this point, I'm aware that other departments have been issued credit cards, and I'm requesting that we have one issued for our department.
Every time we issue a credit card, there could be a problem.
I'm sorry?
Every time we issue a credit card, I know it could be a problem. I think we're sitting there right now with one that got charged from somebody in Alabama.
Was it fraudulent?
Yeah, we've had a couple
Not good.
of fraudulent transactions, different departments,
Hmm.
through no fault of the department.
Right.
I mentioned.
So the risk
You know,
is,
it is.
the risk is
it's
there.
the
where you
risk.
put out, it's there.
You know, the other dilemma that's difficult for Ruth is borrowing somebody else's card is never a great practice anyway.
Right.
You know, it's,
What are these purchases that are difficult?
Well, using the county voucher system is no longer an acceptable practice for some of the vendors we deal with. And at times, we actually end up paying more for items that we need to purchase because, we can only work with those vendors who are willing to work with the county voucher system. So it can,
Is this a problem across the board, or?
well, for example, the Public Works wanted
Yep.
a card because there were, as I understood at the time, there were parts that could be purchased more efficiently. They have a card, they haven't used it. I mean, they've had it 6 months.
That's right, because I put the fear of the Lord in them.
You probably did.
Yeah.
Betty's department, the sheriff's department have cards. I'm sure probably like Ruth's department, there's a lot of training that goes on, and a lot of these seminars or training activities are difficult, I would say, to arrange, right, Ruth, without having a card to reserve.
right.
And it's really not appropriate for an individual to use their card. Yes, you can do that, you can reimburse them, but then you get sales tax issues that sometimes get dragged into it. So, they're a double-edged sword. There, as Ruth outlines, there are instances in which it's very helpful to have one, which you have to be very careful. In RC's office, they're the auditors, we're not the auditors. Remember, we write the check. Somebody certifies to us what the check is to write, we write the check. But you very carefully have to review those charges every month and make sure you don't have fraudulent activity. Or we have a number of classes of vendors that are barred from being charged on the card. That's one of the ways you try to limit the access, so.
We had a problem with the card too last year. Also.
Yeah, we've had two, in two separate departments, and I said no fault of the department, but
Yeah, but I mean, we had a charge last year for getting some other cards with the card.
oh, yeah, I don't know the details of all of that.
That's what RD told me, that I think it came from your department. You gotta make sure they use it right. They can't go out the end of the year, if you got extra money, go out and buy some gift cards or something like that. That's only for purchases.
Oh, I see what you're saying.
And I understand that happened, so you gotta make sure that doesn't happen if these guys decide to give you a card. gotta be used for, you know.
Vendor
certain
purchases
things.
only.
Right.
Do we have written procedures for each
Well,
department?
we're acting under a temporary policy, yes. We do have a credit card policy.
And it would be the same for each
It
department?
would, and RC will provide that. We have, there's several aspects to credit cards. Do you take credit cards? That's one whole policy and procedure. Can you use credit cards? That's another. So when you talk about credit cards globally, there's hundreds of issues that we have to look at.
I know our dean has finally got, he's got a handle on it now about what vendors and how and why and everything, all kinds of recommendations.
Right.
Would you approve every one of these credit card thing, you personally?
Oh, yes,
Okay, it's gonna run
Yeah.
through you, so
absolutely.
if something happens, we come to you.
That's
It's
right.
your fault.
Right.
Okay. Mr. Blanchard moves in.
I'll second.
Mr. Raymond seconds. Further discussion or comments? All in favor?
Aye.
Opposed? You got it, Ruth.
Thank you.
Okay, we're down to,
We're down to the big ones.
we got
The first is to create a new position, staff social work position in the alcohol and drug program. As I've mentioned previously to HHS and personnel, we continue to monitor activities, units of service, productivity throughout the clinic, which of course includes both mental health and drug and alcohol. And when we compare activities between 2016 and 17, we see a pretty dramatic increase in the amount of services and the demand for our services. Also, please remember, we are now engaging in open access, which means when people need to get into the clinic, all they need to do is walk in. We've gone to that model in order to get prepared for value-based payments or what's sometimes called pay for performance. But in working with managed care organizations, the expectation is that people will have access to your services in a timely manner, and open access is the preferred model. So in order to keep the front door open, we've also got to, while we keep that front door open, new people coming in, we've also got to be able to provide quality treatment for those individuals who are already enrolled in the clinic. And at this point, caseloads are brimming over full. We are, there is no room on schedules for individuals to be seen the number of times they should be seen. For example, when somebody first is open to drug and alcohol services, they're sometimes seen 3 times a week. It's that level of intensity that's required at the beginning of treatment. As they progress, then those appointments get more spread out. There simply isn't enough room on people's schedules to provide what's really required in terms of care. OASIS, we're way above what OASIS recommends or wants us to be at in terms of caseload size. And then added to this is the heroin, ongoing heroin and meth is there's an uptick with meth. Is this ongoing problem in Chenango County with substance abuse, and we're getting hit in every direction in that respect. So this position is being requested at this time. I do have on your sheet, you can see that the first item, ADA, a social worker, the cost of the position would be $83,167.50. The revenue produced, and this is based on real figures in our clinic, would be $88,290.90. So actually reducing the local share by $5,123.40.
What does VAP stand for?
Vital access provider. We're not We're not looking at that yet, we're looking at the top item, ADAS.
Okay.
Ruth,
Yes.
same thing I said yesterday. I have a big problem. I won't vote yes on either one of these. But my problem is timing. You know, here we are in a new budget cycle, and here we are in January. We're going to spend $170,000 more, even though you're going to get the money, you think. And maybe a lot of people on this committee don't know. I've sat here a long time, and I've seen it. People tell us, yeah, we're going to get the money, and we don't get it. So I have concerns about that too. I don't know if you need this person this year or not. So you say you do, I guess I should believe you. But I'm not sure you can't live through the next budget cycle without it. So that's where I'm coming from. It's not a personal thing to me. It's just, you know.
No, I understand.
Where's Jeff's committee coming from?
I was just gonna tell you my position on this, I guess. Every year, we ask our department heads to do more with the same amount of local share or less. And we've got a proposal before us that is proposing less local share. How can we not do it? I mean, that's where I come from, I guess.
We kind of been down those roads though, Jeff. We've been
Right.
told it's gonna be there and then it doesn't show up, and this department has particularly had issues with that. I mean, many times we come back and find out something was billed incorrectly, and now we paid $400,000, and, you know, and like, it's just, you know, it's a little bit of the, you know, wondering, yeah, it says it's gonna be there, but is it gonna be there, or? You know, I'm just thinking this, how many people are these social workers at alcohol and drug abuse seeing in a day?
In a day,
I guess start with this, how many are there? How many actual providers are there?
right now on the alcohol and drug side, there are 5.
You got
There are
5 providers.
clinicians.
These are people who actually sit down and talk to people who have problems.
That's correct.
Okay. And how many people are they seeing?
Well, at any given point in time, and this was what was enrolled in the program as of last Thursday or Friday when I was getting ready to come here. And the alcohol and drug program, at any given time, there's roughly 266 individuals enrolled in treatment. Sometimes those people are seen multiple times.
Sure.
Sometimes, you know,
And like you
it
said
varies.
before, they
Right.
start their 3, they don't 1 or
Right.
2. Okay.
And it also, the other factor in that is the intensity of the actual service. And that's why when we talk about productivity, we talk about weighted units of service, because some services take an hour and a half and are billed, you know, at a much higher rate, and of course, and then some services are, you know, 20 minutes, 30 minutes. And so, you know, the number of patients seen or the number of services delivered, it varies, and it's of course highly individualized.
So is it reasonable to assume, though, you got 5 providers that they can see 8 people a day at 1 an hour? When you add
A
them
day
up,
is
the
7
hour and a half
and a
guy
half.
and the 20-minute
Yeah.
guy, and
I think the expectation, you know, we give them sort of goals to, we want at least 6 face-to-face. How much time that actually takes will vary, but that's, you know, if they're gonna hit their productivity goal, that's what they need to be shooting for. In the alcohol and drug program, these folks are working way beyond what we would want them to be doing in terms of the number of people they're seeing, also the intensity of what they're actually dealing with. When you have an addict, a heroin addict, walk into the clinic and ask for help, I mean, that can take hours, and multiple clinicians might be, you know, touching, you know, down with that individual and with family members, including.
how many of these 266 are heroin addicts?
I don't know. I don't know the answer to that. I can find out how many we're currently treating that have a history of opioid abuse. Rarely does someone come in and it's only one substance.
Okay.
Rarely, it's, you know, that's hardly ever happening.
Difficult question, is there an average time frame for recovery? as far as somebody coming out and
That's actually one of the nice things about the Oasis side of the clinic is there is the expectation that people will move from the beginning, middle, and end in treatment within 14 months.
14
Mhm.
So in a 14-month rotation, you average, we figure we're somewhere around 266 patients.
Right.
At any one time.
And keep in mind, some people are successful in treatment. Some people
Sure.
require several stabs
Then
at
you
it.
get them back.
And oftentimes, particularly with the heroin or opioid addicted folks, they're in and out of detox and inpatient too. So that can interrupt the clock, so to speak.
So these 266 people, are they seen on a weekly basis?
Yes, at least. At least.
That's 53 people per provider,
Right, yeah, that's what
plus whatever paperwork is associated with each visit.
Sure.
I presume that's ridiculous.
And
Yeah.
and scheduled time off, everyone, it's vacation time and other issues.
Of these 266 people, how many of them are DWIs?
I'd have to look that up, Dennis.
But there's a group that are DWIs.
There
That's part of the deal, right? You
Right.
go, right?
They're referred.
And before that used to be a large group. I'm sure it probably still is a large part of it. And they all get together as a group, the DWI people.
I don't believe so. And it also varies on how much what's happening out in the community. If they're doing checks, if there's a lot of that activity, then of course we get more referrals into the clinic for DWI.
I know before we went through this, there was a DWI, and then come to find out that DWI people were counted. But they saw 20 of them at once, and it was a class once a week. I mean, so the number was kind of askew because of that, so.
I remember back in the HHS community days, you talked about the Affordable Care Act, and what that did was that mandated that mental health be treated exactly the same and interconnected or interfaced with physical the physical ailments of somebody. So when you start getting into mental health, I always felt it was a very vulnerable, cost escalating situation where all of a sudden, when I'm in school board meetings, we have to have 3 social workers, 2 psychiatrists. We really went top heavy on things that it was just impossible to prove success or to validate that these things were working. So, I mean, are we treating symptoms at an expense of $80,000 and then we're not looking at the root causes? I mean, is this just one more thing that we just keep adding on top of it because we have to do something, but at the same time, you can't get out of the cycle. I mean, how do you, the whole intention of it is to help people, but we can't even prove how we do it, can we? There's no measuring stick or litmus test, is there?
That's a big question. That requires, I think, a lengthy investigation to identify those root causes. I'm certainly not in a place today to.
Right. Well, I was saying that before you added, you increase the head count. You look to those things and say, what exactly is it? These are good intentions, but is it? You have to judge it by its results, and we're not doing that. We're doing it backwards.
Do you know how many of the 266 are repeats?
I don't. I can easily find out because we have all that data. To your comment, Mr. Corey, we don't direct enough focus or resources towards prevention, and we slashed prevention the last 10 years, and there's some of us that believe that you pay now or you pay more later, and I think we're in a situation where we're paying more later, and but the house is on fire. So, I'd love to talk prevention. I'd love to identify those root causes. I'd love to come up with a community strategic plan to slow this stuff down. But right now, the house is on fire, and I need some help.
Well, just to respond to that, the government drives a lot of these issues, and when we look back at the mandates or the the interference, and I would call it that, when the government creates a pain management program that emphasizes the use of opioids, and that became the number one priority. The unintended consequences or something like this. So I just to keep increasing the headcount is really avoiding the important questions. That's what I'm saying. We care for people, but at the same time we want to do it right.
Right. As I said yesterday, and I think I mentioned in HHS, I think since I arrived here in the county, I've really worked hard to right-size my department. Anytime that there's been a change in funding, a loss in funding, I've adjusted the staffing. I've not come back to this group and asked you to support a position that can't be sustained on its own going forward. I believe I've been a good steward of the resources that I have available to me, and I also believe that I've worked hard to balance my role as the local governmental unit, which is to make sure that there are adequate services available across the county for individuals who have a mental disability. But I've been able to balance that with understanding that it comes with a cost, and that it needs to be. I need to carefully consider that exposure and that risk. And I believe over the years I've reduced the local share in both programs. Well, now it's 3, and that's something I take seriously.
You've got 5 providers, and even looking at an 8-hour day, you spend an hour a week with each client. That's only 40 people you're going to see, and you got 53. So that tells me you're understaffed.
If you can believe the numbers, Pete, I think a lot of that is these 266 people. The first thing is that DWI thing. That might reduce that down tremendously. And then how often are they being seen? And it goes on and on and on, and like it does get very complicated. But I see what you're saying.
Would you like to table this and bring further information?
No, I don't think it's going to help at all. I think you and I are going to vote against it, and everybody else is going to vote for it. Why don't we try and see what happens?
Further questions for Ruth?
I'm just gonna state that I support this position just because of what the opioid factor is out there. I think we're the first town to put a drug box, collection box outside. The police chief's looking at that every other day, and every other day for the last month now, there's been drugs in that. It's pharmaceutical drugs coming in, but this is, as far as Sherburne with Bill Lacey, the mayor, and stuff, we've been working hard because this is costing us a lot of money all over the board. If this kind of helps out, and if it does work out as it's a washout, I have no problem with it.
The only thing is, boy, we've heard that story now for 50 years. We've
I've
heard
only
it
heard
for
it for 8.
Heard it for 50, 60 years. We're going to spend money on this thing, and we're going to make it better. And the county population keeps dropping, and we keep spending more. It's like, where's the end? I mean, there is no end. We're stewards of we're just have created an institution, and we're going to spend the money to do it.
And I have a problem with the timing too, like I said. If it's budget time,
Yeah, that is kind of an issue too. How come she wasn't there at budget time if the money was there? So why bring it up now? Because politically it'll pass. That's why.
Further discussion or questions? Someone gonna move it or? Mr. Martin gonna move it? Mr. Mastro seconds. All in favor?
Aye.
All opposed?
Aye.
It does not carry.
Who opposed? I didn't catch that.
Brown. Corey and Outwater. Okay. Next. Nurse.
Yes, so this is in the mental health budget, a community mental health nurse position. For the past several years, and you just mentioned this earlier, Mr. Corey, there's been an increased focus and demand to integrate physical health and behavioral health. There are now changes in primary care settings where they're doing behavioral health screenings. And on our behavioral health side in our clinic, we're now required by OASIS and OMH to do a lot more activities in terms of monitoring, assessing, and referring individuals for physical health care. DOH has consistently communicated this. This is included in all the managed care plans. And right now I have one community mental health nurse, an RN, and I have, for a total of 1,126 patients. At any given day, again, on the mental health side, there are approximately 860 patients who are open for services, and on alcohol and drug, as I previously stated, 266. We currently cannot keep up with what's required by OMH and OASIS in order to gather physical health information, assess, monitor, and refer. By the way, all of those activities are revenue-producing activities. So, this is yet another area where we're falling short in terms of the quality of our services because we simply don't have adequate staffing, nursing staffing for this. Our antipsychotic injections continue to prove to be highly effective in keeping people out of the hospital, and these injections can only be administered by an RN. When we applied for the VAP grant or Vital Access Provider Grant, we did include this item in our initial application, which was approved. We held off until now because I wanted to make sure that this position would be, could be sustainable going forward after the VAP grant ends. The VAP grant will be finished after the first quarter of 2019. So for all of 2018 up until the first quarter of 2019, we will have those additional VAP dollars to cover the entire expense of this position while also experiencing the revenue that will be generated as a result of this new position.
I'm confused what this person's gonna do. They're
Provide-
physical,
Yeah, provide nursing services in the clinic.
for a physical problem, not a mental problem.
No, it's both.
So you got, okay,
It's both. So they'll be gathering health information that our clinicians aren't qualified to gather, and the nurse pulls that information, makes referrals to physical health providers in the community.
why
and then
isn't this,
coordinates that
why
care.
isn't this something that either the public health nurses could do or the nurses at the hospital? Why do we have to do it?
These are services that we're expected to provide in our behavioral health clinic, and we get paid for it.
I guess you gotta give me an example, because I'm really
Okay.
confused what this person
Um,
does.
A lot of individuals who are on a psychotropic medication end up developing metabolic disorders.
Okay.
Cardiac is common, diabetes is common.
This is a result of the drug they're taking.
Yeah, and it complicates it, yes.
Okay, right.
And this is a population that doesn't take good care of themselves.
Okay.
Okay, they don't go to the doctor to prevent illness. They wait until things are really bad, and then they go to the ER, or they need hospitalization, and that's generally the Medicaid population. So we're paying a lot of money to try to keep these people well. So the physical conditions then trigger the mental health conditions trigger the physical health conditions, and at some point, it doesn't matter which came first, it's all mixed together.
Okay, and you need somebody to evaluate that. That's what this nurse is gonna do.
Provide those services that are billable to provide, assessing, referring, doing the injections,
Ruth,
yes.
do you need one person, or would you be able to use half a person? Don't you know that?
Well, just based on what we know we're missing
Where
out.
I'm going is, I
Yeah.
wondered if Mark's got any could his nurses provide this service if they have the time?
Not adequately.
Question? Mr. Blanchard moves. There a second? Marion seconds. Further discussion or questions?
One question. Is this something, it's funded for the first year, first 12 months, plus revenue. Is this something we could look at in a year and say, yes, we do have enough revenue to continue to support this? And if we don't, rescind the position?
Well, we certainly need to have it, if it goes through, we certainly need to have next year's budget. We don't need to wait in January again. I mean, I would be in favor of putting it in the budget and then taking it out versus not having it in there. You know, if it looks like you're gonna get it, and you're sure you're gonna get it, then it needs to go into next year's budget or whatever.
Yeah,
I'm talking about, not this, I'm talking about what would happen when we're doing the 19 budget.
Sure. Yeah.
Further comments or questions? We have a motion and a second on the floor. All in favor?
Aye.
3 opposed.
Aye.
Aye. Does not carry. Okay.
Can I just, is that all?
That's it?
Can I say a few? Seconds? Okay, I just want to make sure I understand, what happened here. So despite my history of working with the county to right-size my department over the years and reduce local share, despite the fact that these two new positions will actually reduce the local share in both budgets in 2018, despite the fact that the state VAP dollars that have already arrived in the county will completely cover the cost for that community mental health nurse position for all of 2018 and the first quarter of 2019, and going forward will be completely covered by the revenues it generates, despite the fact that we are experiencing a drug epidemic in Chenango County that is creating havoc with our families, in our families, and in our communities, despite the fact that on any given day in our clinic we are serving approximately 15% of the entire population in Chenango County. Despite all that I've stated, Finance Committee has voted against these two new positions. Did I get that right?
Yes.
Thank you.
I would say to you the same thing as my boss used to tell me back in the days when I worked in the real world. That, and I would go in and ask for a person or two, would say, you probably need it, but go out and do the best job you can.
You know I will.
I know you will.
Okay, thank you.